thinking when you said that postmenopausal phase rate of depression are equal between men and women. One of the thoughts that came in was, oh, do we need to wait till then for things to settle? Because
pre-pubertal also we are sort of having equal rates of depression.
Therapute is an organization that is aimed at creating mental health awareness. We are also committed in making mental health services more accessible. So welcome you all to today's conversation on women's mental health and well-being. We have with us our speaker for today, Dr. Geetha. It's a great pleasure to invite Dr. Geetha Desai. Dr. Geetha Desai she's completed her MD, DNB. She also holds a PhD degree. She is a professor in the Department of Psychiatry at National Institute of Mental Health and Neurosciences, Bangalore. She is also part of the perinatal services there. Out of her various research and clinical interest, one of the most prominent interest areas are women's mental health. So it's indeed our privilege to have one of the country's best to speak about mental health, women's mental health and well-being on Therapeutes platform here. Welcome you, ma'am. Gender is a very crucial determinant of both mental health and mental illness. And we are all very well aware of how societal structure and power differentials favors one gender over another. Yet another important factor is how women's bodies are very different and how that contributes to certain susceptibilities and exposure to specific mental health risk factors. And that's the reason we are having this conversation today. And in today's conversation would be focusing more on women's mental health concerns across their various reproductive life cycle stages. So, ma'am, what are your thoughts on having this conversation specifically on women's mental health?
Gender, I think especially in terms of mental health, it becomes very important because definitely there is a difference in terms of how disorders present and how they respond to treatment and how there are certain gender specific factors which are actually related in terms of causation of illness. I would use the term causation because I think they're very, very important. Otherwise, how would, like for example, if somebody has depression, how does it matter whether it's a man or a woman? Because there are certain set of symptoms. But as research has very clearly shown that the manifestations are very different, treatment responses are very different. And if you simply treat the illness, we might not really be treating the person. That is, basically, we're not mitigating many of the risk factors that a woman experiences. So I think in that sense, it's very important. The second thing is there are biological vulnerabilities. There's no doubt about it. And there are biological differences in the way, the man's brain and women's brain functions in certain areas. I'm not saying there are lots of differences, but these differences are important. And they're also linked to a lot of reproductive hormones that events that a woman goes through. So there's a biological basis why we should be studying differently. At the same time, the psychosocial factors, which actually, like for example, gender-based discrimination and violence, we know that they are linked to particular mental health conditions. So I think it's not that we look at these as independent, they are actually dependent. What happened, biological vulnerabilities as well as psychosocial vulnerabilities. I think these two factors are very, very important in making, women's mental health a separate topic. And also, I think everybody should be aware of it. Let me start from the beginning. So you are less likely to be educated. You're likely to stay in household where there's more chances of violence. You're also probably likely to be subjected to certain kind of trauma, if I would say, by basically physical assault, violence. And when you don't have education, when you don't have control over finances, when you are subjected to so many, so it's not just about socioeconomic, one leading to another. And then these, multiple factors, and at the same time also your things like even proper nutrition. So what happens is you have so many of these factors, and you're likely to get married at a very young age, and then you become pregnant. So you're basically carrying so many of these negative factors forward. So you're pregnant, you already have so many of these adversities and vulnerabilities. So during pregnancy, it might affect the child, and you might likely to give birth to a low birth weight child. And then it just doesn't stop there. And then subsequent pregnancies, no control over contraception, no control over the family size. Again, you also are probably in a relationship where again your control over finances is not there. So you it's just continuous, cascade of events, one after another. So that's the reason why I think socioeconomic factors. If you have education, then if you're earning, then probably if you have, you're more likely to be aware of what are the mental health condition, you're likely to access treatment. You're able to go to the specialists and get treatment, early treatment, and pay for the services. So many of these things right now. So if the woman is depressed, she has to ask someone else for the financial support to go and seek treatment. So that's another barrier. And also, okay, let me also put it the other way around. How do health professionals treat women? So women are more likely labeled as being very emotional, or probably this is how they are. So even if they are depressed, it can work either way. So either they can be snubbed as, they are women and this is how their life is. They have to face these many stresses, and they normalize their distress. Or that because women are more likely to experience emotional disturbances, so you're more likely to be given a prescription of an antidepressant. So it works either ways.
I'm so glad that you brought about these so-called subtle factors, because a lot of young, especially young crowd of clients, the group of clientele that we have, they have their friends or their peers telling them it's a privilege to have a disorder, a depression. It's a privilege to feel depressed. Because you have access to so many things, you can afford to say that, oh, you're worried about something and you're depressed. And often they quote people from low socioeconomic background saying, okay, if you need to struggle on a daily basis for your life, you don't have time to get depressed. But that's not so true. And coming from a mental health professional who is working with people from all socioeconomic backgrounds and who sees how these are affected, I think that was very important. Uh, yeah, and about how women and men have different access to treatment. I remember reading somewhere that men often get specialist treatments where they go to a psychiatrist, or if it's physical or a medical problem, how they have access to specialist treatment, whereas women mostly go to their general physician and get it treated. And so you're also suggesting that there might be a gender bias even among the professionals in how they see women's or general problems.
Yeah, I mean, I think it's because they go to the local, even though the help seeking rates are quite high in women, but what kind of treatment they get is important. But like I also want to highlight here, so it's even though it's hard for women to, but it's also hard for men to talk about depression to their physicians, or most often they're treated for alcohol, substance use, and other related disorders. So, one important thing, even though socioeconomic education or all that, doesn't mean that women from upper socioeconomic status or middle socioeconomic status don't have concerns, because there are gender-based roles which can be often women are considered as perpetual caregivers throughout their lives. So that itself is a very burdensome thing. And and child, when they have children, and balancing work life and things like that. So these all are a lot of changes women goes through.
Now, another common, since we are talking about reproductive life cycles, uh, A common question most young girls and women are met with is it that time of the month when they show anger or express some irritation? What are your, can you tell us a little bit more about premenstrual symptoms and premenstrual syndrome?
I think the premenstrual syndrome and PMDD have been probably the most controversial and discriminatory. A lot of perspectives are there about in terms of diagnosis. So if I speak like a health professional, forget about what the social construct is about menstruation and other things. Of course, menstruation is, nobody talks about it. So premenstrual syndrome, I think it's basically a constellation of symptoms. What we are talking about is predominantly a mood symptoms like anxiety, depression, irritability, and crying spells. And though along with that, many women also experience a lot of physical symptoms and behavioral symptoms. Not everybody will need intervention. It's a subset of women when these symptoms actually starts affecting their functioning or relationships. That's when I think women need to, get. I mean, then only actually the diagnosis and treatment starts. It does exist. There is biological basis on why PMS and PMDD happen, because a woman who's experiencing PMDD is also at risk for developing subsequent depression related to reproductive life events. So it is definitely there, but at the same time, I think it's a balance. So does that mean that women should not be, because of menstruation and other related things, should she be absolved from certain duties? At the same time, it's also subject of ridicule by a lot of people. Everything gets labeled as, oh, that. I mean, you see many of the memes and jokes are on, the women bosses about how, but actually studies have shown that the cognitions per se do not really make a difference during the premenstrual phase. It's only the emotional symptoms and the physical symptoms. And many women manage without medications, but there's a subset of women who really suffer because of these symptoms.
You spoke about how it poses a risk at for women in their reproductive stages if they become pregnant. It was not so comforting to see the rates of pregnant women with mental health concerns. So I read that around 10% of pregnant women have mental health concerns in developed countries and around 15 to 19% in developing countries. What are some of the common issues that are seen in pregnant women?
I mean, I think firstly, the thing is the rates are low because the way we measure psychological distress is very different. The way in low and middle, probably low and middle income developing countries, the rates are actually quite high when compared to the developed nations. So, I mean, prior to this, a lot of people thought that pregnancy is like a very good phase, great mental health. But now we know that, depression and also the focus is so much on depression that a lot of other disorders are forgotten, common mental disorder. A lot of them have anxieties during pregnancy, fear of childbirth. Many of these are not taken into account. So if you take all these, probably the rates might go up. So in terms of what are the risk factors for why do women develop mental health problems during, so if a woman has had any past history, I mean, before she became pregnant, has had past history of depression or anxiety and is currently not on treatment, she can have a relapse during pregnancy. Second thing, which has also been very strongly linked to antenatal depression, has also been violence, experiencing violence in the intimate relationship. And in our country, one of the things that has emerged is the gender of the infant. There's a lot of pressure for women to have male babies. So that's another important factor which has been linked to antenatal depression. The other concern, I mean, having poor social support, high risk pregnancies. I think probably we need to, also address infertility right now. That's, I think, another area where we need to talk about psychological issues. But as such, I think during pregnancy, some of these, like for example, women having hyperemesis throughout the pregnancies, having poor social support, or having a lot of complications. So some of these things actually pose risk for women to develop depression during pregnancy. And why is it that it is important that we address depression and anxiety during pregnancy? Many women don't want to be aware, or they're scared to seek help because they think that they have to take medication. And they're also not supposed to feel that way. They're supposed to feel happy all the time. And I think that's another reason why women hesitate to talk about it. And families also sometimes tell them, you're not supposed to feel that way. So these are the reasons why women don't seek help for depression during pregnancy. And I think it's important that in some countries, actually, it's become mandatory that all pregnant women are screened for depression and anxiety, but we still have a long way to go.
For the benefit of all, can you please tell us about uh, are medications okay? And if somebody has some mental health issue, if not okay, like a common mental disorder like anxiety or depression, when they are planning pregnancy, what are some of the things that they should be doing?
I think first, if you're planning pregnancy, medication is one is having a good mental health is very important. So ensure that when you plan pregnancy that you are on treatment and you've kind of taken care of it. So for mild to moderate problems, there are evidence-based psychological interventions which actually work for both anxiety and depression, antenatal depression. So these are the first preferred line of treatments. But if the woman has very severe depression and has had suicidal ideations, or constantly having those thoughts about dying, then probably she might need medications. And there are we need to probably take into consideration all many other factors before we prescribe medications.
So we spoke about prenatal period. Now, baby blues are something again which is very common, and how that leads to postnatal issues, and is that common? Having baby blues is common.
I think baby blues, the studies have reported up to 50 to 80% of women in the first week post childbirth do experience baby blues, intense emotionality.
Oh,
Yeah, I think because it's a self-limiting condition, they're very tearful, lability is there, suddenly they feel joyous, suddenly they are crying, not able to sleep, which will resolve within 3 4 days. So it's not of major concern. But if it be very severe and persistent, then probably it becomes a risk factor for postnatal depression. In fact, for postnatal depression, one of the risk factors is and having somebody have mothers having depression during pregnancy. So that's one of the important things, and also the childbirth experience. What we've also seen is many mothers have complications during childbirth, or have had some sort of an obstetric violence, which we talk about, having a very poor childbirth, lot of pain they have experienced, and complications, baby being separated from the mother post childbirth into an NICU for reasons, and mothers not allowed to see the child. So many of these things actually can or let's say some mother is very keen on giving a natural birth, but then had to undergo emergency cesarean section. So all these could potentially could be risk factors for developing postpartum depression.
uh, lack of support from family or relationship issues between partners, does that also contribute?
In fact, one of the, like I was mentioning, intimate partner violence is it's a negative event. But what is it that can mitigate it is also having a positive, supportive spouse is something that is considered as a protective factor. At least some of the social support, like for example, post baby, if the mother is, or what happens often is, the woman most often goes to the mother's place. So there are people to look after the baby, look after the mother as well. So things are, that amount of support, instrumental support as well as emotional support is very important. And I think, reducing the anxiety about how to breastfeed the child, and, because the changes are happening so fast, sometimes the mothers are quite anxious. So if you have a support, these anxieties can be taken care of.
Uh, Okay, I was just thinking if we need to talk about mother-infant bonding issues.
Okay, I mean, I think sometimes motherhood is also given very, very glorified. Your mothers are expected to feel an instant love for the child as soon as the baby is born. So often women find it very hard when they don't get those feelings, because somewhere that the moment they don't get that feelings, they feel that they failed as mothers or there's something wrong with them. Even during pregnancy, there's a lot of literature to say that how moms actually can, imagine things about how the baby might look and how the baby might be. And but what we've seen in Indian mothers is they're not very vociferous or vocal about how their experiences are, especially when the baby is inside the womb. But post delivery, I think the mother needs some time, because the first few weeks, the baby is, sleep a lot of time, and the babies often just feed, and, eye contact is not much. But it takes some weeks for the baby's mothers to develop that bond. Now, the reason why so much of emphasis is, I mean, there are a lot of disorders that children are known to develop if there are attachment bonding issues between the mother and the infant. So there are ways of assessing, but I always feel I think we should give some time and ensure allay the anxieties of the mother to bond with the baby, facilitate. Sometimes just because somebody is very anxious, they may feel, oh, will I drop the baby? Will I do something to the baby? I'm not very confident. This anxiety itself it's not the predominantly bonding problem, because they're so anxious, they may not be able to actually, be relaxed, and they may get frightened if the baby starts crying. So some of these, so it is very important, but I think it's also the very sensitive issue. All of us have to be very as supportive as possible.
Okay, moving ahead. So infertility, since you mentioned infertility, it undoubtedly puts a lot of burden on both physical and psychological on women. So, yeah, so I was talking about how it places a lot of burden on women and the mental health consequences related to infertility. So,
Okay, I mean, I think we need to probably gender becomes a very important construct here, especially in infertility. So, woman's identity is determined by whether she is able to bear a child or not. And I think that is the pressure the woman has once she is married. Unless you are able to bear a child, your identity. And there are a lot of things that are quite difficult. A woman who has not had a child is not allowed to attend certain functions. There's a social exclusion which happens. So in that background, they come and often the fingers are always pointed towards the women regarding infertility. So it becomes very important for us to I think if this already the woman has infertility issues, and then there are issues in the marriage in terms of poor marital support. The third element that comes is many of the IVF treatments are quite intrusive, and the success rates are poor. They're expensive. Also, it can be quite traumatic for women. So and some of the treatments are really uh, I wouldn't say challenging, but the way women perceive it is it's very unnatural, and that anxiety about whether will it succeed, not succeed, and what are the other options. So these are some of the things that, and sometimes the spouse might not cooperate for many of the investigations. So the burden actually falls on women in infertility treatment. So I think that's another thing. And so there's now, in fact, the psychological distress was so high in women who were seeking IVF treatments. So many of these IVF centers have made it mandatory to have a mental health professionals who will actually do the assessments and provide psychological support.
Oh, that's a great move.
I mean, it is important. It is important.
And as you mentioned, the social messages is such that at the end of it, women, it is seen as a sense of failure or incompetency in them. It's so personalized and it becomes their failure and not
Yeah.
the couple's problem anymore.
Yeah, I mean, I think that that's the way, and most of sometimes even women are not even aware how this whole belief has been ingrained into them from. So they kind of take it upon themselves, to have babies, and they go to any extent to get these treatments done.
And these are yeah, so it can be burdening by all means. I know that they're very expensive treatments, very intense treatments, and not the first time. It's not sure that the first time it will be successful. Many of people are doing a couple of treatments. So by all means, this is a very exhausting and psychologically painful experience, I feel.
Absolutely.
We move to the last reproductive cycle of women. Uh, so in India, most women attain menopause also at a time where children are leaving home. Uh, there, some women are at the top of their career. There are also a lot of other things happening in their surroundings, like uh, dealing with their parents, their previous generations, caregiving, their children leaving home. And some of the menopausal issues are, again, like any other mental health concern, this is again fought with a shock and feeling overwhelmed on how to deal with it.
Yeah, I mean, I think there's a lot written about emptiness syndrome.
Yes, yeah.
So where kids leave, and then so I think it's probably also one need to understand at the what at that point of time, it's not only just that the kids are leaving, plus if the woman is working, there are different sort of issues at the workplace, at where they are supposed to reach a particular level. There is a biological vulnerability for perimenopausal depression. If you look at the rates of depression, postmenopause, men and women have almost equal rates, but perimenopausal, the rates actually increase. So that's because I think that's the time the hormones actually kind of reduce and estrogen and progesterone come down, and so they're more likely to experience. And if they've had a past episode, or if they've had premenstrual dysphoric disorder, they're more likely to have depression. Now, treating depression at that time is a challenge because it may not respond very well to just the antidepressants. So sometimes even hormone replacement therapies, and of course, like I think that's another area of discussion in terms of how safe are they, and but these are the treatments that are available. And I think it is important that some changes are part of normal natural menopause. Like, for example, somebody having hot flushes, or having a low mood and in sleep difficulty. Some of these symptoms resolve on their own, so they might not need medication. But some have syndromal depression. It's like a disorder. So these are the women, I think, who need to be treated for depression. And also at that point of time, I mean, even though we kind of the hormones are looked at in a negative way, but I think these hormones are quite beneficial for women, because we know that estrogen is quite protective, cardioprotective, bone health is okay, cognition is better. But after that, the risks kind of, becomes quite almost equal to men. So while I'm was just kind of, we're just talking about only reproductive life events. I think there are many other things about women's mental health. One is about body image. I think there is a lot of pressure to look, especially among young women, to look in a particular way, to have a perfect weight. And I think that's another reason, even though PMDD is something that we spoke about, but there's also this lot of pressure to be in a particular way. I think body image disturbances are quite there, and I think we really need to
Sure.
probably address them too.
Maybe on a different talk, we'll have you here again to talk about body image disturbances.
Okay.
But I was, I was just thinking when you said that postmenopausal phase rate of depression are equal between men and women. One of the thoughts that came in was, oh, do we need to wait till then for things to settle?
Oh,
Because
yeah. Pre-pubertal also we are sort of having equal rates of depression. It's just the puberty to menopause, menarche to menopause.
phase,
Yeah.
that's a long phase.
Yes.
But another thought that came in, I was thinking, uh, menopause is also a sign. So 45, 50 might also be the career peak for some women. And
Yes.
uh, then to face this is almost a signal that you are physiologically aging. How is
Yes.
that dealt with?
Um, I mean, there's a positive, it can be a positive experience. You know, the woman who's had been the care provider and looking after children probably might get some respite to do things on her own. That's one way of looking at it. Or else, I think sometimes there are many methods of dealing with aging.
Hmm.
Like for example, taking care of your health. I think that's the time when many of the metabolic disorders like diabetes, hypertensions are also likely to set in. So, getting yourself evaluated or some of the reproductive organ related cancers, screening for them, I think these are something that are very, very important that need to be done. Second thing, one is, accepting the change in roles, change. I think acceptance is something that, and also being prepared for it. Often, these things don't happen suddenly. They are all, happen over a period of time. So it's a bit of a larger question than how women's roles need to be looked beyond of being a mother, being, a spouse. So I think it's important for the women to do that. But there are some therapy. I mean, most often, many women don't really need treatment in that sense, because over a period of time these symptoms settle down. Only when they develop a disorder we need to treat.
Thank you, ma'am. I know that, we covered such a long span of cycles in very short time, and I'm sure I had to rush you through some areas, given time you had a lot to speak on each of these spaces. Last takeaway message that on women's mental health and well-being that you have to tell to our audience.
Um, I think I know that all women here are carers
And two, I
in
think
some
many.
way, men or carers. So I think it's important to focus on your health, mental health. So develop certain habits that will have influence in terms of your mental health. Be aware of your emotions. See how you want to let go of few things. Let go of things that, don't hold on to things. Try and see if you can. I mean, in terms of make health your priority. And what else? Physical exercise for women. Then, in fact, one of the things that I want to encourage women is encourage sisterhood. Basically, be there for another woman at any point. I mean, all of us can make a difference. We are health professionals, that's a different matter. But try and see whether you can be there for other women. You can, and I think that's, see, systemic changes will come slowly, but then we need to work, take small steps ahead. I think that's the thing I wanted to tell.
That's wonderful. And we are indeed in touch message.
Okay.
Thank you so much for taking time out of your very, very busy schedule. It means a lot to us. It was wonderful having you here and hearing from you, ma'am.
Okay, thanks, Fasli, and thanks for such wonderful questions.
Thank you, everyone.
Yeah.
Thank you.
You can reach out to Therapeute with queries related to mental health. And before you go, don't forget to like, comment, share, and subscribe to our Therapeute channel. Thanks for watching. See you very soon.